The patient is a 52-year-old homemaker and is vegetarian. She has ill-fitting and uncomfortable bridge works done by other dentists 5 years ago. She would like to redo her dental works definitively and is interested in dental implants but has a limited budget. Medical history is clear, but otherwise the patient has hypotension. On examination, the patient has a slightly lower facial third due to collapsed bridge work, failing upper and lower bridge work. She has fair oral hygiene, but there is difficulty in maintenance due to the failing bridge work, and BPE score at the moment is 3. The patient's mouth is relatively small and has a correspondingly small and narrow arch. The diagnosis includes inadequately root-treated 3.5 and 3.7 with marginal leakage and caries, in which they were re-endo-treated and was presented in a separate case study. There is mainly occlusal discrepancy due to failing bridge work, where the top and lower bridges are mobile. Discussion of treatment options are listed in the clinical write-up. Definitive comprehensive treatment plan include the elimination of disease, where caries control, extraction of hopeless teeth, endodontic and re-endodontic treatment of vital key teeth, namely the 3.5 and 3.7, were followed out. Implant therapy on the upper arch using the all-on-4 principle has been implemented with root banking in the future with a fixed long span bridge work on the maxilla. Plan extension from the 1.6 to the 2.6. At this moment, the occlusion is not finalized and currently rehabilitated with a long-term resin provisional bridge. This casework focuses on the redoing of the lower bridge work, utilizing the 3.5 and the 3.7 as an abutment of a 3-unit bridge. This acts as an adjunctive long-term provisional, which will be cemented with polycarboxylate cement. The patient is actually keen on implant therapy to replace the missing 3.6 but unable to afford so, and will consider doing that a few years later. The patient is not too keen on having shortened dental arch and would like the posterior left teeth to be restored, and thus a 3-unit bridge treatment plan has been implemented. Originally, the old bridge work was a 4-unit bridge using the 3.4 as well as an additional abutment. However, from basic periodontal examination, we see no mobility in that region, no pocketing, and it is not a problem, and the 3.4 is then converted into an individual crown. The 3.5 and 3.7 have been endodontically retreated and has been symptom-free then. A fiber post is placed into the adequately prepared 2.5 to provide additional retention, and resin-modified glass ionomer cement is filled into the 3.7 to act as a nail core. Fortunately, 2 mm of supragingival tooth structure remains, and thus a ferrule effect is achievable. The cores were allowed to set, and preparation consistent with the crown and bridge preparation protocol has been implemented. The wrist and the handpiece of the clinician has been locked in its attempt to create a path of insertion as parallel as possible for the insertion of the 3-unit bridge on the prepared abutment teeth. Fortunately, the bulk of the added post and core material facilitates this possibility. Impressions are then taken in a one-stage technique with additional silicone using a double retraction cord. Provisionals are placed mainly on the functional teeth 3-4 and 3-5 for cuspal protection and pulp protection, as the 3-4 is still vital. The 3-7 is left alone as it is a non-functioning tooth, and this is to save cost of material. The case is then sent to the technician to have the definitive bridge fabricated and issued. The crown of the 3-4 is cemented with a resin cement, and it is left there definitively. However, the 3-unit bridge has been cemented with zinc oxide polycarboxylate, adequate enough for retention and kept in view for any form of retrievability, as the patient is interested in having implant placed in the edentulous ridge of the 3-6 area to replace that tooth. And when that happens, the 3-unit bridge will later be converted into individual crowns